Thank you, Chairperson, for your nice words of introduction, and thank you, Vijayakumar, for offering me this session to talk on one of the oldest molecules in the practice of diabetes. In fact, when Dr. Vijayakumar asked me to talk on this topic, I was a little worried because he has asked me to talk about a molecule which has been there for decades. And I don't know what is new to tell this august audience about the older molecule. And when I realized that after me, three giants are going to talk on the newer molecules, which are current, I was even more worried. However, I will try to present data to justify that sulfonylureas, especially the modern sulfonylureas. I am going to focus only on glimepiride along with metformin as still a place in the management of type 2 diabetes, especially in countries like India. So we know that sulfonylureas have been in clinical practice for almost 70 years, and the molecules have served us very well. But unfortunately, despite their established efficacy and safety, with the advent of the newer molecules in the recent time, there are opinion that is there a place for the sulfonylureas in the management of type 2 diabetes. So there is a need to relook at the data about sulfonylureas and establish, yes, there is still a place for the management of type 2 diabetes with sulfonylureas. We know the journey started in 1942 when sulfonylureas were discovered, and there were a number of trials and tribulations, one of the worst being the UGDP program, which condemned sulfonylureas. Then, of course, it culminated in 2023, last year, with the joint Asian Development Diabetes Evaluation Program, which again endorsed the need for sulfonylureas, at least in some of the Asian countries, because of economic reasons. So the question to be answered today is there a place for sulfonylureas in the management of type 2 diabetes? In fact, I can emphatically say that in a country like ours, sulfonylureas have been one of the most important molecules after metformin. Very often we ask what is after metformin, and we know that in our country, sulfonylureas have remained as one of the best add-on to metformin for very long time. And even in those patients who do not tolerate metformin, sulfonylureas have been advocated as an alternative medicine. And of course, even in countries like developed countries, SU remains largely prescribed where new drugs are available or they are very costly. Many of the patients cannot afford, in spite of the fact that we have now generic forms of all the costly medicines. Even then, compared to those medicines, sulfonylureas are much cheaper, and they are preferred over these newer molecules in many of the countries. So sulfonylureas, we know, have good efficacy. They are durable. There have been questions about the durability of sulfonylureas. I will tell you why they are durable in my subsequent slides. And of course, one of the questions is about weight gain. And we know that modern sulfonylureas, like glimepiride, do not cause much weight gain. And hypoglycemia is another problem associated with sulfonylurea. It's very true that with older generation sulfonylureas by glibenclamide, it was a huge problem. But again, we know that with modern sulfonylureas, glimepiride and glycoside, hypoglycemia, if appropriately chosen dose is given, can be reduced to a large extent. And of course, sulfonylureas are still the choice of drug for almost 20% of the type 2 diabetic patients in our country. And in fact, sulfonylureas, 35% of the Indian population are a combination of sulfonylurea and metformin, even in 2024, when newer molecules are available. They have a long track record of good efficacy. Adherence is very important in diabetes. We know people adhere when you give a combination of sulfonylurea with metformin, and good tolerability is also there, although you have to be very careful about avoiding hypoglycemia and weight gain. And we know that they are insulin secretagogues. As an add-on to metformin, they can be complementary to each other. So there are several benefits with reference to sulfonylureas. They are well tolerated, reliably reduce glucose. We know that their effect is immediate, allow once daily oral dosing very often, have pleiotropic benefits, especially glimepiride has been shown to have some pleiotropic effects, and of course, they rarely cause symptomatic side effects other than, of course, hypoglycemia, which again I would like to emphasize, only when used in inappropriate doses in wrong patients, then hypoglycemia can be a problem. Then, of course, we know that one of the most important pathological defect in type 2 diabetes, initial defect, is loss of first phase insulin secretion. It has been shown that glimepiride has the potential to restore first phase insulin secretion, especially if given in the early part of the disease process, which is very, very beneficial for those patients with type 2 diabetes. And as I told you, it has got a number of pleiotropic effects. It inhibits metabolic clearance of insulin, so more insulin is available. Inhibits glucagon secretion, another important pathological process in type 2 diabetes. Improves insulin sensitization and decreases insulin resistance in peripheral tissues. And unlike the older generation, conventional sulfonylureas, it does not interfere with ischemic preconditioning, which is one of the, again, worries about using sulfonylureas in type 2 diabetes. It decreases toxic, the reactive oxygen, reactive glycation end products, and of course, it reduces the inflammatory markers, VEGF and FGF2 levels, and of course, it also induces the granulocyte number, and also the granulocyte macrophage numbers, which improves the vascular health in type 2 diabetes. We know that the macrovascular disease is one of the most important complications of diabetes, and glimepiride has been shown to improve the vascular health in type 2 diabetic patients. And among all the oral agents which are now used in the management of type 2 diabetes, sulfonylureas are the only one which can produce A1C reduction of up to 2. Whereas all the other molecules can produce A1C reduction of, say, about 0.5 to 1%. Again, the efficacy is much better compared to other sulfonylureas. So, of course, there is a question about weight gain. You have to understand that the weight gain is part and parcel of the pharmacokinetics of sulfonylureas. They reduce the glucose immediately, reduce glucotoxicity, reduce glucosuria, so that more glucose is available for metabolism. Naturally, there will be some weight gain. But again, I would like to re-emphasize that with modern sulfonylurea, this is not a big problem, again, if you use appropriate dosage. Of course, sulfonylureas are still option as an add-on to metformin. As I told you, one of the largely prescribed drug as an add-on to metformin. The efficacy is high. It is well tolerated with metformin. Of course, risk of hypoglycemia is there, but very moderate with modern hypoglycemias. Weight gain, again, can be minimized. Cardiovascular safety, it is neutral. A1C reduction up to 2%. And of course, the most important point, especially in a country like India, the cost is very low. So the combination, we know that sulfonylureas are insulin secretagogues. So we know one of the most important pathological processes is reduced insulin secretion. The other one is insulin resistance. So the sulfonylurea can take care of the insulin secretory defect, and metformin can take care of the insulin resistance, and both together can act on the liver and take on the most important third pathological process in diabetes, namely the insulin resistance in the liver and increased neoglucogenesis from the liver. So three important pathological processes, the trade of pathological process in diabetes, can be taken care of by a combination of metformin and glimepiride. So it has been compared with all the other molecules that are available for treatment of diabetes today. So one of the studies showed that compared to DPP-4 inhibitors, glimepiride can produce 12% greater reduction in A1C, better reduction in fasting hyperglycemia, and of course, a more number of patients achieve A1C reduction below 7 and significantly fewer dropouts. That is very, very important. So many patients continue these tablets for long periods of time. It has been compared with these SGLT2 inhibitors. Two studies have looked at it. One is the EMPIRIC H2 HSU trial, which compared empagliflozin with glimepiride. Another one, CANTATA-SU trial, which compared canagliflozin with glimepiride. And both the studies have very clearly shown that glimepiride is non-inferior to these SGLT2 inhibitors. And of course, it has also been compared with one of the GLP-1 receptor agonists, the exenatide, as an add-on to metformin, and it has been shown that the dose-dependent variability has been observed in terms of glycemic control. But even though glimepiride was used in minimal dose, it showed better efficacy compared to even a GLP-1 receptor agonist like exenatide. So it can be combined with insulin. This is another big advantage. It can be complementary. So many people fear that if you give sulfonylureas with insulin, hypoglycemia and weight gain can be a problem. But what has been shown is that when you give sulfonylureas along with insulin, there can be up to 30% reduction in the daily dose of insulin, which again will reduce the weight gain and hypoglycemia associated with this combination. Of course, one recent study has shown that a combination of glimepiride with metformin is a good choice for the treatment of some types of maturity onset of diabetes in the young, MODY. This again is a recent study with small numbers, needs more exploration. But there are a lot of myths and about sulfonylureas. One is about the durability, the myth of beta cell exhaustion. We always believe that they can accelerate the beta cell apoptosis and result in beta cell failure. One study looked at over a period of 10 years the changes in A1C and the C-peptide level and looked how these molecules reduce the beta cell reserve. The result showed that an increase in A1C was associated with beta cell acceleration of beta cell apoptosis and beta cell failure, but it was not the sulfonylurea. If you maintain the glycemic control at a good level, then sulfonylureas did not lead to acceleration of beta cell apoptosis. So long-term treatment with sulfonylureas had no detrimental effect on long-term changes in the beta cell function. Then of course, the data from UKPDS, the follow-up of 10-year follow-up UKPDS very clearly showed that even a 1% reduction in A1C can result in very perceptible reduction in macro and microvascular complications of diabetes, and many of these patients were on sulfonylureas, especially glimepiride, again emphasizing that sulfonylureas can be very good in reducing micro and macrovascular complications of diabetes. And none other than Dr. Hoffman, one of the lead authors of the UKPDS, he said no solid evidence for beta cell exhaustion in the clinical setting over 6 years in the UKPDS. Diabetes may itself cause the decline in beta cell function, but it is not the sulfonylureas which cause beta cell exhaustion. Of course, one of the most important questions very often asked is the cardiac safety of sulfonylureas. One of the doubts is whether they interfere with ischemic preconditioning. So it has again been shown that glimepiride do not interfere with ischemic preconditioning. This was a trial where they looked at the mean ST segment depression during repeated ballooning of the coronary arteries, giving one placebo, glibenclamide, and glimepiride. They showed that glimepiride did not interfere with ischemic preconditioning, whereas glibenclamide might interfere with ischemic preconditioning. So again, you can very safely use glimepiride in type 2 diabetic patients. And of course, the proof of pudding is the Carolina trial, which compared linagliptin with the glimepiride. And again, most of these patients had established, 42% had established cardiovascular disease, 37% displayed at least more than 2 risk factors for diabetes. What was the result? As far as efficacy was concerned, both linagliptin and the glimepiride produced the same A1C reduction. But to look at the 3-point MACE, there was no difference between the two. In fact, the linagliptin, the 3-point MACE was 11.8%. It was 12% for glimepiride, again showing that 3-point MACE is not adversely affected by glimepiride compared to linagliptin. Another study looked at the all-cause and cardiovascular mortality between sulfonylureas. Again, you can see that it is very low with glimepiride and of course very high with glibenclamide. So glimepiride again does not increase the cardiovascular morbidity and mortality. And of course, another study looked at, it's a meta-analysis of 47 trials, looked at the association between the use of sulfonylureas and all-cause cardiovascular mortality. Again, very clearly showed that glimepiride does not increase all-cause mortality and cardiovascular mortality. Of course, all of you know about the veteran first trial, the follow-up 10 years. Again, it showed that the intensive group, which was treated with glimepiride, had a robust 17% risk reduction in major cardiovascular events. Again, reaffirming the role of sulfonylureas in the management of type 2 diabetes. And what about the recent cardiovascular outcome trials with the SGLT2 inhibitors? Again, you have to remember a large percentage, in some of the studies, 50% of these patients who were included in these cardiovascular outcome trials were on sulfonylureas. So again, showing us that sulfonylureas may not be the cause for increased cardiovascular morbidity and mortality. And of course, the latest evidence, this was last year, 2023, on cardiovascular safety of modern sulfonylureas. This was by the European Society of Cardiology. It said that sulfonylureas, especially glimepiride, significantly lower all-cause mortality, cardiovascular mortality, and number of hospitalization and emergency visits for heart failure and hospitalization, for acute myocardial infarction and stroke with glimepiride. Long-term continuous glimepiride use associated with better survival, fewer hospitalizations, and emergency visits for heart failure. And high-dose glimepiride, 2 to 4 milligram, was associated with, in fact, lower cardiovascular mortality. This was from the European Society of Cardiology in 2023. And of course, cardiovascular safety in type 2, again, this was from the American Diabetes Association 2022. It came to the conclusion that second-line sulfonylureas for glucose lowering are unlikely to increase cardiovascular risk or all-cause mortality. SUs are cost-effective and have widespread use and should remain part of the global diabetes treatment program. This was from the American Diabetes Association in 2022. You may ask about the SGLT2 inhibitors. This study compared glimepiride with dapagliflozin and looked at the cardiovascular morbidity and mortality. And what did it conclude? It said both glimepiride and dapagliflozin significantly improved glycemic control, insulin resistance, as indicated by HOMA-IR, and NT-proBNP, that is very important, with no significant difference between them in type 2 diabetes patients. And since both drugs have improved the levels of NT-proBNP, they can be recommended for diabetic patients who are at high risk for developing cardiovascular disease. Again, comparing with one of the latest molecules, the dapagliflozin. Now, there are certain murmurs are being raised. This may be a little controversial. This was a consensus statement from a group of endocrinologists from UK last year, 2 years back. They said cardiovascular outcomes relating to anti-diabetes medications are providing a pseudo blanket to our understanding of the cardiovascular events of the newer agents, cardiovascular effects of the newer agents, and pose significant cost and conduct challenges. The regulatory body should have a rethink on the strategy for drug approval relating to type 2 diabetes, as the current trials are enormously costly and consuming huge amount of resources, which may pose a major risk for the future development of new diabetes drugs. They said that ethnic variations may be present in efficacy and adverse events to a drug, in addition to challenges in weight-based dosing. So one of the challenges would be to design trials to satisfy needs for different regulatory agencies. This was a statement from a group of endocrinologists from UK last year. So modern sulfonylureas are preferred in the Indian context. This was the South Asian Federation of Endocrinologists in 2017. They came out with a consensus statement saying that they are cost-effective and oral route of administration can help in adherence. Of course, this is from the American Diabetes Association 2 years back. Modern sulfonylureas should be preferred over conventional sulfonylureas in view of the reduced mortality, all-cause and cardiovascular mortality, better CV outcomes, and renal protection. So choose later generation sulfonylureas to lower risk of hypoglycemia. And the consensus statement said glimepiride has shown a similar CV safety to DPP-4 inhibitors. 2017 IDF endorsed sulfonylureas in the management of type 2 diabetes. ADA in 2008 again re-emphasized that they do have a role in the management of type 2 diabetes. And this year, the clinical practice recommendation by the American Diabetic Association again says that if you want a potent drug, when the newer molecules have failed to achieve hemoglobin target, you can still use sulfonylureas for reducing A1C levels. So there is a wall of evidence. Cardiovascular safety should no longer be a concern when choosing sulfonylureas, especially glimepiride, for people with type 2 diabetes. And of course, one study has shown that even at 15 years of use, if you withdraw sulfonylureas, you may land in trouble. The blood sugar shoots up. So always continue sulfonylurea, maybe with a reduced dose, because they may have extra pancreatic effects also. Of course, you may ask what is the evidence for Indian use. A number of studies since 2015 to 2023 are very clear. Can I take 2 to 3 more minutes? Yeah. So a number of studies have looked at the use of the modern sulfonylureas and come out with favorable results that they are very safe in the Indian context. So you have to remember that Indian diabetes needs Indian solution. So the modern sulfonylureas are appropriate, available, affordable, and accessible, and clinicians got reassurance about the CV safety of glimepiride, and economy makes it patient-friendly OSA. So remember, cost is very, very important in a country like ours. So many of these patients have to spend from the pocket. And one of the studies recently showed that one of the most important causes for non-compliance is cost. So we have to keep that in mind. And should sulfonylurea remain an acceptable first-line add-on to metformin therapy in patients with type 2 DM? Yes, the answer is yes. The ideal anti-hyperglycemic agent should be easy to administer, unlikely to cause symptomatic side effects that pose barriers, adherence, inexpensive, reliably efficacious, and safe. By such standards, it can be argued that the modern sulfonylureas do very well even in 2024. I will try to conclude by quoting author Conan Doyle, the famous author of Sherlock Holmes. He said, "Never theorize before you have data. Invariably, you end up twisting facts to suit theories instead of theories to suit facts." So, ladies and gentlemen, concluding, sulfonylureas are important component in the treatment of type 2 diabetes. Efficacy, they cause maximum reduction in A1C, have durable action, and beta cell exhaustion with sulfonylurea is a myth. Modern sulfonylureas cause negligible weight gain and lesser hypoglycemia. Due to their well-established efficacy and safety profile, sulfonylureas are the most frequently used with metformin. Modern sulfonylureas are not associated with risk of increased cardiovascular mortality. They are cost-effective, and combination with other agents are essential component of effective type 2 diabetes management. And newer sulfonylureas like glimepiride are cardiovascular safe, same endorsed by the recent guidelines like ADA and IDF. Thank you very much.